Thank you so much, and nice to be in the small city compared to Chicago. But it's tough to follow that. But I'm so glad that Dr. McKenzie talked about data because I don't want to talk about data. I'll just talk about how I approach it, what I see, and what I do, and how I fail, which apparently is a lot since I get invited for complication talks. The older options that we had for ISR was just cross it, balloon it, and reline it maybe, and just line it and line it and line it. Nowadays, we talk about crossing it, ballooning it, maybe doing debulking, maybe doing thrombectomy, adding drug-coated technology, and whatever have you. The data, I'm going to skip over this because we just covered exactly this. The only other one I looked at was we have the Leipzig data on Rotarex plus DCB. I think they had 128 patients with about an 85, 90% patency in 1 year, so that's great. So I think the most important thing we got to think about is how not to find yourself in this, which we can't always do, but I'll show you a case of mine from several years ago. And if you don't know this movie, you should watch it. This is me on a tough calcified CTO probably about 8 years ago. And you can see what's happening here. This is not pretty. I'm very kind of subminimal going around this heavy calcium. And you know what I did next is put this wonderful stent, and then I'm stuck in a perpetual hell. Because what's going to happen when the stent like this, there's nothing I'm going to do to make this better after laying down the scaffolds, is I'm going to get into this problem where I think it looks great. You know, these are one of those pictures where you take it real quick, you step off the pedal, and you're like, looks great. The fellow has no chance to see how bad that is. And then they come back recurrently occluded, recurrently stenosed. You're going to see it. It's just a matter of how many days. And you see this, and some of the recans alone, what Andre is showing is similar to that, just going retrograde and snaring it and outbacking it. Just because I did a crappy job, I didn't have better tools at the time, the patient was deemed a non-bypass candidate. Just by me, just kidding. So then you snare it, you pull it, you floss it, you do all these things, and guess what? Still get a benefit. It looks great on that duplex and the segmentals for that first week, and then they're going to come back. So don't do that. We know it's going to happen with bare metal stents no matter what we do. We can try to reduce it as a goal, but once you have it, how do I approach it? Here's a case, patient in his 60s has been treated with stenting, obviously at the other hospitals in Chicago, not mine, and came in recently with recurrence of claudication type symptoms. And this is what we see. We see a typical pattern of stent in that third image. You see that multifocal kind of areas of occlusion, maybe thread-like, and you go at it. This is the distal runoff. You can see the outflow is not great. And I think we need to address that more and more as we understand more, with maybe considering improving outflows with whatever means we have to. Brian Fisher talked about this, good friend, about IVUS. I think it's important we understand what we're treating and why. We have so many tools, but how do we choose? Maybe if we see what's in there, we can have an educated decision. And please consider using it, because insurance companies are reactionary trying to cut it out. I was on 2 calls with all the societies, and it's hilarious what they're trying to say about it. But you can see what's in there. You can see your calcium or thrombus or plaque or whatever have you. So in these situations, I do typically use laser. I've used Rotarex. I just prefer laser in most of these. I'll use a 2-3 with the turbo power and just let it spin as I go. I think I see a lot of people doing just a quick pass, and you may not get the good result. You got to go slow and steady. I do prefer filter protection. We talked about the data. It's important to know what that hyperplastic tissue that we're seeing in there. You can see the results of just from histology when you add some kind of debulking with drug-coated versus just balloons. So I think it's important. IVUS will show you what's in there. I use a filter, and you can see this is the turbo power. When you spin it, it circles. I have both RU on and Phillips, so I'll use both in certain situations, but for this, I like to see it spin around there and go slow. I just sped it up for you guys. Sometimes you have recalcitrant disease in there, and then I'll go aggressive with scoring balloons because you have to do whatever you can to improve that lumen, and then I'll do DCB. In this patient, I was worried about the runoff, so he had one good runoff. I messed with the one that was already diseased and tried to improve that, and did do better for the next 2 years. Don't be a fool, because sometimes you'll see this stenting, and you get across, and you see this disease here. You can see there's an occlusion here on the third image of the stents. Pretty bad runoff. You can see there's already been some surgery for the veins gone, so I'm in the clear. So you can see the runoff is there. Now, I'm pretty damn good with my hands, but I'm not that good. If your wire does this, I'll speed it up just for the audience. Yes, of course, that's me, but still, one thing I remember is that there's probably clot, whether you use IVUS or not. So I used to, in the past, put an infusion catheter either for 20 minutes or for overnight. But nowadays what I'll do is when my wire does that, I'm going to pass thrombectomy. Now you can do this with some of the devices, but for me, I like the robustness of pulling out everything I can. Some people do this just with a sheath. I do like to do aspiration thrombectomy. You can do this with Obviously, the aspiration element of the RE1, you can do this with Rotarex. Some people use Jetstream, whatever have you. So I'll do that in these kind of cases. And you'll be surprised at what you can get after you relieve it. You got to base it on the acuity of symptoms. You got to base it on what they're presenting with, and then it will require adjunctive ballooning and whatever have you. So this was the final on that patient. So the backup plan for that was lysis. There's options for Rotarex, laser with aspiration. I can do it for long CTOs as well. I would pass a wire. I call it the laser cat technique. This is the creepy images that show up when you Google that. But I'll do the aspiration first, and then I'll typically with a filter do laser, because whatever's left behind that incited that lesion, you might be able to treat it with thrombectomy, and this is the stuff that comes out. Whenever someone tells you don't use protection, especially a lot of reps, 100% of the time use protection, just like in high school. It's very important. So my approach is, if I see an ISR, especially with cover stents, I cross with relative ease, I'm going to automatically do the 7 French or 8 French sheath, try to aspirate whatever I can. Then I consider atherectomy, which I know is a dangerous word. Then I'll use plain balloons, aggressive balloons, and I'll try to end it with DCB if I can, whatever else adjunctive you need. You'll be surprised. This is, I thought, subacute chronic, whatever it was. But if you think about what came out, this is what came out of here. I don't think just ballooning this would have been smart. So whatever you can get out of there, I don't know what debulking device would do this either, but I was able to aspirate that out. And just to finish up, one thing in ISR, there's also tibial ISR, don't forget. This, again, was a person who put a bad tibial stent, not me, of course. You can see the stenosis here in the outflow. That's going to be a problem. You can see this hyperplastic hyperplasia, and this is the problem here. And once you've stented, it's tough. Sometimes you can try a little uniqueness. I tried lasering that, ballooning the heck out of it, and you can see the caliber actually changed. It's not going to be perfect, but whenever you have a stent that's put in and never fully expanded, you have to try to do whatever you can to improve it. Otherwise, you're going to go into that perpetuity of hell that I showed you before. So, number one, don't stent badly. We have a lot of tools for vessel prep. That first case I showed you, I would have shocked that if I had that tool now, and I would have tried to prevent that horrible stenting. So this is me. If I cross, I'm not that good. Think about thrombus. I look at IVUS if I can to see what's in there. I choose laser, and then ballooning with or minus the aggressiveness. If there's stent issues we talked about, consider stent grafts. Consider relining it like Andre showed. And if there's thrombus issues that can't lyse, cannot thrombectomy, maybe covered stent for those, but just protect those collaterals. And I try to DCB at the end. I think our data has kind of shown that helps in most of our patients. Thank you.